So good evening, everybody. It's a great pleasure to be here. I'm going to just close this down so you can actually see me. So both myself and Francis Horgan, who's going to come after me, are going to talk about beyond the acute management of stroke. So what happens after you get beyond that point? What kind of issues might you be facing? So I'd maybe just quickly kind of go over what David has spoken about, which is the common after effects of stroke. So weakness on one side of the body would be very common. And typically that would be on the side opposite to the side of the brain that has been affected by the stroke, and can also affect the face. But we heard Ken's wonderful story where the clot retrieval meant that that actually disappeared. So with the advances now that are happening in acute stroke care, a lot of these issues can be treated in that acute phase. Another area where people would experience difficulties quite frequently would be in relation to speech. And that's both in producing speech, but also in understanding speech. So sometimes you can speak, but you have difficulty interpreting the spoken word, which can be very frustrating. And psychological difficulties, we know, are also common. So people have difficulties with cognition and have difficulties with mood. And I'll go into more detail on these. So internationally, the context of stroke is that it is the second most common cause of death worldwide for adults, and it's a leading contributor to adult disability. And we know that with the kinds of difficulties people face after stroke, that there is a lot of availability of rehabilitation for physical function, for physical problems, but there is really not so much for cognitive impairment. So really that whole area of where people are struggling with memory and with cognition generally, there is very little rehabilitation, and for that reason it's referred to very often as the lost dimension of stroke rehabilitation. It tends not to feature. So what does cognitive impairment mean? So the kind of common issues that people might complain about after having a stroke is that they feel their memory has been affected, so in particular short-term memory. So just have difficulty, certainly for the days immediately after the stroke, maybe remembering things that are happening. And often that might recover spontaneously, but for some people that will continue. And for some people, the extent of that memory difficulty is more pronounced, so they're having greater difficulty. Another common area of difficulty would be in what's called executive function. And executive function means that people have real difficulty concentrating after having a stroke. So they have difficulty paying attention to things and to being able to concentrate. They find their minds wandering all the time, and they're distracted very easily, and that has a huge effect on memory then. So if you are not paying attention, you're not actually encoding information, so therefore you can't remember it. So they all kind of feed into each other. People might have difficulty processing information, they might have difficulty with the speed with which they can process information, and then they may have perceptual problems. And common perceptual problems would be visual problems, where you might not be able to see part of your visual field because there's an area at the back of your brain has been affected, or that you have speech difficulties. And by perceptual speech problems, I mean people have difficulty understanding speech, not producing it. So they have no difficulty with their hearing, there's no deafness, but there's an inability to process the information. So the international evidence is that people who have had a stroke describe cognitive impairment as the most difficult stroke outcome to deal with. And it's the biggest obstacle or the biggest thing that prevents people from getting back to their pre-stroke way of life. So back to work or back to their normal day-to-day routine. Cognitive impairment prevents that more than any other outcome of stroke. And we also know that in a situation where somebody is having recurrent strokes over a period of time, they are at increased risk for developing vascular dementia. So if people have repeated strokes, then we know about 1 in 3 people will develop what's called vascular dementia. In terms of the effects of stroke on mood, one of the things people complain about directly after a stroke is a profound fatigue. So people feel very exhausted. Their energy levels are very low, and that may last for a couple of days, it may last for a couple of weeks, it could stretch into months, or it could be a kind of a permanent outcome of stroke. And people can find that very difficult to get used to. They may have been quite energetic people prior to their stroke. And so because of the frustration of just feeling so tired all the time, it can affect people's mood. So very often then people begin to feel quite low in themselves, maybe feel a bit depressed, and also maybe feel quite anxious. So there is that kind of fatigue and low mood would not be uncommon after stroke. And the feelings of anxiety and depression are linked to, things that are very reasonable. So you're now adjusting maybe to your body's function and capability not being what it was. You have to adapt to, in a way, a new way that your body is working. You may have difficulties with speech that are very frustrating. So either you can't say what you want to say, or you're having difficulty understanding what people are saying to you. And that is, very frustrating. You may be very worried about returning to work. So again, I've used the picture of Andrew Marr, who most of you will probably know, who was out of work for the best part of a year, I think, before he came back. And he has come back to work now with an obvious disability on his left side. So he has returned to work, but during that period after stroke, you're very worried about whether you'll be able to get back to work again. So that's obviously very, anxiety provoking. But if you're retired or if you work at home, then you're worried about getting back to your normal life, getting back to your normal social life, getting out and about again. There is an intense anxiety for many people about having another stroke. So having a stroke feels like the rug's been pulled out from under you. Maybe you've been very healthy up until that point. So there is the anxiety then that it might happen again, and how do you prevent that? And then there's a whole new world in terms of managing your medications, managing doctor's visits, going to see rehabilitation specialists, managing the rehabilitation at home. So a lot of new things that you're trying to integrate into your life, and all of these things I think contribute as well to anxiety and depression. So as I said, it's frequently present in early weeks. It can extend beyond that, and for some people it extends for quite some time beyond that, and so managing that kind of mood after effect can be a challenge. So I'm going to very quickly go through the Irish context of stroke in terms of just the last 10-year period. So if we go back to 2006, and David talked about in the 1980s the kind of lack of treatments that were available for stroke, but 10 years ago in Ireland we had no information on stroke. And where you've no information on the numbers of people having stroke every year or the numbers of people with stroke in the community, how can you plan health services? So you just can't. So there were no statistics in relation to stroke in Ireland 10 years ago. We had no data on acute care, intermediate rehabilitation care or long-term care. So no idea how many people who had a stroke eventually go into a nursing home because they can't be managed at home. We had no data on stroke rehabilitation, either in hospital or in the community. We had no data on the organisational structures in relation to stroke. We knew we had no stroke units, but we didn't really know anything else. We had very little data on stroke outcomes and probably only knew about mortality outcomes, and that was it. And no information on primary or secondary health promotion, preventative health promotion activities. And it was really difficult to engage the government because we were in the Celtic Tiger era, so building houses was really more important than just about anything else. So what happened then? So around 2005, 2006, there was a tipping point, and a number of things contributed to that. So one of the most important ones, and I was at a meeting this morning where they talked about the biggest momentum, the biggest driver of change in the health service is having the Minister for Health on board. So having their ear, their sympathy. The Minister was sympathetic because a member of the Minister's family had had a stroke. So they had experienced stroke services in Ireland and they were very aware of where there were shortcomings. So the Minister's ear was available. We had at that time a number of stroke specialist physicians returning to Ireland to take up consultants posts from the US and from the UK. So they had been trained in the UK or the US. They were very familiar with dealing with high quality data in those countries, and they were coming back to Ireland and saying, this is a disgrace, it's an embarrassment, we need to have good quality data to be able to provide good health care. There was very significant pressure from charities, and in particular the Irish Heart Foundation, and we'll be hearing from the Irish Heart Foundation later on. And that pressure from the Irish Heart Foundation meant that philanthropic funding became available. So Atlantic Philanthropies put some money forward to have a comprehensive study done in Ireland on stroke, on the condition that the Irish government matched that funding. So the Department of Health matched the funding provided philanthropically, and the first comprehensive national audit of stroke services took place in Ireland in 2006-2007. So what did it show us? To some extent, people already knew this, but for the first time now we actually could put numbers on it. So we could see that there were significant shortfalls in stroke service provision, both in hospitals and in the community in Ireland. And there was an urgent need for a national strategy for stroke, a reconfiguration of hospital services so that there were acute stroke units available nationally, that we had rehabilitation at all stages of care, both in hospital and in the community, that we had a stroke register so that every single patient who had a stroke in Ireland was registered, so we knew how many strokes were happening in Ireland every year, and that we would address gaps in rehabilitation services post-stroke, and in particular that there were no psychological services available either in the hospital or in the community in Ireland. So the impact of that fed into a national cardiovascular health policy that was published in 2010. It is our current health policy. It's bringing us to 2019. And I think it's fair to say that there have been huge strides in terms of the acute management of stroke. And an awful lot of the energy and the focus has been on developing really state-of-the-art acute stroke services. But there are still gaps in community care for people with stroke. So once people go home from the hospital, what's available in the community is very patchy. And that creates a big difficulty, and it creates a big difficulty in relation to rehabilitation, which I'll talk a little bit about, and so will Francis. But for the first time in Ireland, in terms of a cardiovascular health policy, up until then we had a heart health policy. We now have stroke care and rehabilitation embedded in this policy, and that's important to have it at that policy level, because that gives you some leverage in terms of trying to put the squeeze on politicians to give some money to this area. So then the next thing which we anticipated is that as soon as you approach politicians to talk about improving stroke care, the first question that will come back to you is, well, how much is it going to cost? So working with colleagues in the ESRI who led on these studies, there was a cost of stroke in Ireland study conducted and published in 2010, which looked at the costing of acute stroke care. And the conclusion of that, in a nutshell, very briefly, is, and it was a complicated project, but that if you invest money now in establishing stroke units, and if you ensure best practice care, so that there at that time was thrombolysis available nationally, now we're looking at thrombectomy, having that rolled out nationally, which is a challenge. But ultimately, because you're enabling somebody to have the best possible outcome after a stroke, you are ultimately saving money, because you are reducing the need for long-term care, which is very costly. So, we're looking at maybe nursing home care, costs an awful lot of money. So if you invest now, and people's quality of life is hugely enhanced by getting that best possible care, then you ultimately will save money. So more recently, and again led by the ESRI, we conducted the cost of stroke rehabilitation in Ireland study. And again, this looked at provision of rehabilitation, both primarily after leaving hospital. And again, and in brief, the conclusion was that if you invest money now in providing comprehensive rehabilitation for people after a stroke, you will ultimately save money, because the combination of state-of-the-art acute stroke management and the medications that are prescribed after that, along with rehabilitation, means that each person achieves their best potential after having a stroke, and ultimately that will save money for the health service, if we want to put it in that crude kind of way. So I'm just now going to move to current Irish research to just give you an insight into what we're doing at the moment. David spoke about the Aspire study. It was it recruited people who'd had a stroke in 2011 while still in hospital, and followed people up then 6 months later. And it was looking at the people's medication use and whether it was controlling their risk factors for stroke, but also looking at people's rehabilitation needs after they left hospital and whether those needs were being met. And it also spoke to people's primary caregivers. So the person who was most close to that person, it may have been their spouse, it could have been an adult child, or it could have been a sibling. But we spoke to that person to see if they were satisfied with the care that was provided, if they were satisfied that they understood what had happened and that they understand what now needs to happen. And we looked at the impact of providing care on the caregiver 6 months after stroke. So what we know from that study, which at 6 months, was that over half of patients in that sample, and there were 256 patients followed up at 6 months, over half of them had cognitive impairment. And if we applied a really, really conservative measure of cognitive impairment, 40% of people were found to have cognitive impairment. So that's a lot of people. It's 2 in 5 people who'd had a stroke had cognitive impairment 6 months later. We also found that 1 in 3 patients had moderate to high levels of anxiety. So again, people, very anxious about a whole range of things relating to their stroke. And about 1 in 5 people had moderate to high levels of depression. So a lot of psychological after effects really of stroke, and there was no rehabilitation in relation to that. We know from more recent work that's been done, so the second national stroke audit was published in December 2015, and this was hospital focused only. The community focused audit is going to be published quite soon. And we know from that study that we now have a majority of people with stroke in Ireland who are managed in a stroke unit, which is what you would want. Over 90% of patients will see a stroke specialist nurse. Over 80% will see a physiotherapist. 1.6% of people will see a psychologist. So even though there is a lot of cognitive impairment and mood issues after stroke, very few people are seeing somebody who can help to rehabilitate that. So currently, as of this month, we're now recalling that Aspire-S cohort. And so it'll be a 5-year follow-up of stroke. And a lot of research in stroke doesn't do that type of long-term follow-up. So this is an important thing to do, is to follow people up 5 years later to see how are they doing. And the Aspire-S2, as we're calling it, will look at these 4 areas in particular. So it will look at longer-term secondary prevention after stroke. So the longer-term medication management really of people after stroke to make sure their blood pressure is under control, their cholesterol is within normal limits, and all of those very important things. We'll be looking as well to see at 5 years, do people still have rehabilitation needs? And if they have them, are those needs being met? Can they access rehabilitation? And if they are accessing rehabilitation, how are they doing it? Are they paying for it themselves, or is the HSE supporting them to access physiotherapy or speech and language therapy or whatever people might need? We'll be looking at people's longer term cognition and mood status, and we will also be speaking to the person's primary carer. So we'll be speaking to them again to see what their perspective is on the way things are and how things are impacting on them personally. As part of Aspire-S2, the focus on cognition is being led by a researcher called Daniela Roda, who's in the audience up there, who's doing a PhD in this area. And so Daniela is looking in particular at the fact that people have to take a lot of medications after they have a stroke, and it's important that they adhere to them and take them properly. And if people, and people often don't adhere to their medications properly, that's true of all of us. If you're on a course of antibiotics, when you're feeling rotten, you'll probably take it 3 times a day for the first 2 days, and then you forget as you start to feel better. So to actually take your medications every day at the right time is a challenge. And it's made even more challenging if you have cognitive impairment. So, your memory mightn't be the best anyway. So that creates a greater difficulty. So what Daniela's focusing on is looking at people who had low adherence to their medications at the 6-month follow-up that we did in 2011-2012. So if you had poor adherence, does that predict further stroke, we'll say, in the 5 years, up to the 5-year follow-up? And also, if you're poor on adherence, I think I have it on the next slide actually. Yeah, so if your adherence is suboptimal to your medications, does that mean that you are more likely to have cognitive impairment at 5 years, or that you may have had further stroke in that 5-year period? But also to see if you are detected as having cognitive impairment at 6 months, how does that affect your adherence to medications in the subsequent 4.5 years? And if you are adherent to your medications, is that because your primary carer is actually, giving you the medications at the right times every day? So how are you managing that? And then looking to see if cognitive impairment and suboptimal adherence to your medications increases your risk for further stroke. So it's really looking at that kind of bi-directional relationship between adherence and cognitive impairment. And then we'll be looking at the need for appropriate intervention and what that intervention might be to support people in being adherent. And then another research program, and this is the last bit that I'll talk about, is called the StrokeCog study. And this study has just gotten off the ground in June of this year. So this is really a program of research that has a number of Irish researchers, both in RCSI and beyond, but also researchers with expertise in this area based in the UK and in France. So the StrokeCog study is a program of research that has 3 interrelated, what we call work packages. So they're like 3 separate studies running in parallel. And there are 3 postdoctoral researchers who are working on this project for 3 years. It commenced in June of this year. It will complete in about September of 2019. The 3 work packages, or the 3 kind of studies that are involved, are firstly to model post-stroke cognitive impairment and post-stroke dementia. So that really means using information that we have nationally, and that would include things like census data, the census information that we fill in every 5 years. So looking at that kind of national level data and international level information, and to build a picture of the extent of cognitive impairment after stroke, and also the extent of vascular dementia after stroke, and then project that forward by 5 years and by 15 years to 2021 and 2031, because, as David was saying, the population is aging. Age is a risk factor for stroke. So if you have more older people and therefore more stroke, what does that mean for health service planning? And what does that mean for our need to develop effective interventions now that help people not to really suffer with that kind of cognitive impairment after stroke? So that's the first work package. The second work package is looking at developing an intervention for people who have cognitive impairment after stroke. So a big problem here is that there is no proven intervention to rehabilitate people who have cognitive impairment after stroke. There have been lots of attempts, but nothing really systematic. So we are looking at building an intervention for post-stroke cognitive impairment from scratch, and then feasibility testing it within our health service, and then running a pilot study, and then ideally, if we find it to be effective, rolling that out into a bigger trial that will happen nationally. So that's the focus of the second study. And then the third study is to answer the politicians when we hopefully go and say, we have a really effective intervention for people who have cognitive impairment after stroke. It needs to be made available nationally, because they will say to us, well, how much will that cost? So the third work package is looking at estimating the current costs of post-stroke cognitive impairment in Ireland, and then projecting those costs forward by 5 and 15 years using the data from work package 1, and then looking at the effects of introducing cognitive rehabilitation and making it applicable nationally using the information that's going to come out of work package 2. So they are the 3 studies that are happening in parallel at the moment. So in terms of just the impact, very briefly, the impact will be that it provides important information to health service planners and health service providers so that they can plan ahead for to have effective interventions in place for people who have stroke. And also provides patients and carers and healthcare professionals with a voice in terms of saying their experiences of post-stroke cognitive impairment and the unmet needs they might have encountered. And finally, that we will provide an evidence-based contribution both nationally and internationally to cognitive rehabilitation after stroke. So finally, for me, you'll be glad to hear, if you are interested in being involved in the StrokeCog study, then we are seeking your expert input. So particularly if you are someone who has had a stroke and has experienced cognitive impairment, no matter how mild, then we'd be very interested in talking to you. Or if you're a carer of somebody who has had a stroke and who's experienced cognitive difficulty after stroke, then we would also be very interested in talking to you. So if you're interested in taking part in an interview about that will take about an hour, maybe an hour and a quarter to complete, then please contact me at my email address, which is here, or come down to me maybe after that we finish tonight, and I can take your details. But we would very much value input from both people who've had a stroke or their family members to get a sense of their experiences and what they think is needed to help with rehabilitating in that area. Okay, so thank you very much.